Hello everyone, welcome to another session of ePath for Success. I am Dr. Rahul Mohandas. I am a senior lecturer in the Department of Oral Pathology and Microbiology at Tirumala Institute of Dental Sciences and Research Center, Nizamabad. At the onset, I would like to thank Dr. Sunil sir and the entire team of Pushpagiri Dental College for providing me with this opportunity. I would also like to take this opportunity to thank all my teachers who have supported me in every step and continue to do so. With this, let us start with today's topic. We'll be seeing about Hodgkin's lymphoma. Okay. Before we start Hodgkin's lymphoma, we have to understand the normal lymphoid architecture to understand the pathologies and lying underneath it. Right. So let us understand a normal lymph node. Okay. So this is a normal lymph node. Okay, lymph node is a kidney-shaped structure. Okay, it is an organ where there is lymphocytic aggregation. Okay, you see lot of lymphocytes which are aggregated. Okay, you have two subsets of lymphocytes. You have T lymphocytes and B lymphocytes. Okay, so in your lymph node you have some areas. Okay, first of all, the outermost covering is the fibrous capsule of the lymph node. Okay, after that you will have a cortex and a medulla. Okay, this cortex has the cortex proper and the paracortex region, and you have the medullary sinuses and cords in the medulla. Okay, so in your cortex, what you have your B lymphocytes. Okay, you will have a lot of B lymphocytes. And how are these lymphocytes arranged? They are arranged in follicles. Okay, these follicles are called as lymphoid follicles. You can see here they are lymphoid follicles. Okay, so your cortex has B lymphocyte. Majorly B lymphocytes. Few T lymphocytes will also be seen. Okay. Then your paracortex primarily is populated with T lymphocytes. Okay. So cortex sits with B lymphocytes and paracortex is with T lymphocytes. And what does the medullary sinus and cords contain? They contain majorly the plasma cells. Okay. So here also you can see you have the lymphoid follicles, and these lymphoid follicles basically they're arranged in such a way that they have a outer mantle zone and inner germinal center. Okay, so this gray shade that you see is the germinal center, and this white border is the mantle zone. Okay, histology of lymph node also shows a similar thing. You have this fibrous capsule. Okay, you can see the cortex, medulla, and the medullary sinus. The cortex primarily consists of a lot of lymphoid follicles. Okay, all these are lymphoid follicles, and if you see a lymphoid follicle, you can see a inner light zone, which is the germinal center, and the outer dark zone, that is the mantle zone. Okay, mantle zone and germinal center. What does this germinal center contain? These germinal centers, if you take a larger view of this, it basically contains the naive B cells. Okay, the immature or naive B cells, which are then evolved, or which undergoes evolution to form a centroblast. Okay, this is a centroblast which evolves from a naive B cell. Okay, and how will you differentiate a centroblast? It is a large cell with a large nucleus, and the nucleus is not cleaved. Okay, it is uncleaved. Okay, uncleaved or not cleaved. Whereas when the next stage is the centroblast, it undergoes transition to form a centrocyte. The centrocyte, it has a cleaved nucleus. Can you see there's a notch here, right? So all the cells which have these arrowheads pointed towards them. So this is a cleaved cell. This is a centrocyte. This again is a cleaved cell. It is a centrocyte. Okay. So these large cells are centroblasts, which are uncleaved, and the smaller cells are centrocytes, which are cleaved. Okay. Then these further get evolved into mature B cells, which can either be a memory B cell or a plasma cell, which will release the immunoglobulins. Okay. So these are all the constituents of the germinal center. Okay, so you have a mantle zone outside, you have a germinal center which contains naive B cells, centroblasts which are uncleaved, centrocytes which are cleaved, and the plasma cells and the memory B cells. Okay. So this is how it is evolved. Okay, so you have a mantle zone, then you have a centroblast, the primary B blasts, which are the naive B cells, okay, which undergo transformation to centroblasts, which are uncleaved, centrocytes, which are cleaved, and then secondary B blast cells, which either become a plasma cell and release immunoglobulins, or they become memory B cells. Okay. So when you see a T cell and a B cell subsets of lymphocytes, there are certain antigens which are present on the cell surface of these cells, okay, B cells and T cells. Okay, so based on these receptors or based on these antigens, you can identify whether the lymphocyte is a B lymphocyte or a T lymphocyte. Okay, so in a T cell or a T cell marker or a pan T cell marker, any T cell, it will show a CD3 antigen. Okay, so a CD3 is a pan T cell marker. Okay, how will you remember? T for T cell, T for 3. Okay, so CD3 is a pan T cell marker. Okay, apart from CD3, you will also see CD2, CD28, CD3, CD4, CD8. Remember in HIV, you see CD4 and CD8 T cells, right? So all these antigens will be seen in T cells. Okay? When you come to a B cell lymphocyte or B lymphocyte, the pan B cell marker is CD20. Okay, how will you remember this? In Hindi, 20 is Bs. Okay, so Bs is 20 in Hindi. So B for B cell, B for Bs, which is CD20. Okay, so T for T cell, T for 3, and B for B cell, B for Bs or 20. Okay, this is the pan B cell marker. Apart from 20, you have CD22, CD19, CD40, CD80. Okay, all these are also B cell markers. Okay, but the pan B cell marker is CD20 and pan T cell marker is CD3. Okay. So when you take an immunohistochemistry of a normal lymph node, and when you stain it with a pan B cell marker, which is CD20, you will see that the follicle, okay, the entire follicle, the mantle zone and the germinal center takes up the CD20 positive. Okay, and there are some scattered B cells also which are present in the paracortex region, which are also showing CD20 positivity. Okay. On the other hand, if you stain the section with a pan T cell marker, which is CD3, you will see that the germinal centers or the follicles are not taking much of the stains, but the paracortex region, okay, all these T cells are taking up CD3. Okay, so this is CD20 and this is CD3. Okay, having said that, having understood, about the normal architecture of lymph nodes, now we will go to see what is Hodgkin's lymphoma, okay, and how is it different from non-Hodgkin's lymphoma. Okay, Hodgkin's lymphoma, it is a malignancy of the lymphoid tissue. Okay, and the important thing that you have to remember that histopathologically, you have to identify the Reed-Sternberg cells. Okay, you have to identify the Reed-Sternberg cells. Reed-Sternberg cells are the neoplastic cells which are seen in Hodgkin's lymphoma. Okay, more about that later. First of all, let us understand what are the differences between Hodgkin's lymphoma and non-Hodgkin's lymphoma. Okay, suppose a genie comes to you and he tells you that I can give you a lymphoma. Which lymphoma do you want, Hodgkin's or non-Hodgkin's? We can blindly choose non-Hodgkin's lymphoma. Sorry, we can blindly choose Hodgkin's lymphoma. Okay, why? Because Hodgkin's lymphoma has a better prognosis than non-Hodgkin's lymphoma. Okay, how it is that, we'll see now. So Hodgkin's lymphoma, first of all, it has a localized presentation. Okay, you will see that either one node is involved or a group of lymph nodes of the same chain are involved. Okay, so very localized presentation. Only in advanced cases you will see a widespread presentation in case of Hodgkin's lymphoma. Okay, whereas in non-Hodgkin's lymphoma, the distribution is diffuse. Okay, you will see a widespread distribution or a widespread lesion in non-Hodgkin's lymphoma. Okay, the spread in Hodgkin's lymphoma is in an orderly fashion. It is called as contagious spread. Okay, it spreads from one node to the neighboring node, then from the neighboring node to the neighboring node in that way. Okay, it is called as a contagious spread. It is very predictable. Okay, whereas in case of non-Hodgkin's lymphoma, the spread is not predictable. Okay, it is a very random spread. Okay, then the most commonly affected site for Hodgkin's lymphoma is the cervical lymph nodes, okay, in the neck. Whereas in the non-Hodgkin's lymphoma, the most common site is the hard palate, mucosa of the hard palate and the soft palate. Okay. Then the mesenteric nodes and the Waldeur's ring, which are present, they are rarely affected in case of Hodgkin's lymphoma, whereas it is very commonly affected in non-Hodgkin's lymphoma. And finally, the most important point, histopathologically, the tumor cell or the malignant cell or the neoplastic cell in Hodgkin's lymphoma is the Reed-Sternberg cell. To call a lymphoma Hodgkin's lymphoma, you have to demonstrate Reed-Sternberg cell or its variants. Okay, whereas non-Hodgkin's lymphoma will not show any Reed-Sternberg cells. Okay. So we'll go on to Hodgkin's lymphoma. As I told you, it is a lymphoid malignancy, and the tumor picture will be that there will be a Reed-Sternberg cell or a variant of Reed-Sternberg cells, and in the background you will see the non-neoplastic cells, which are the mixed inflammatory cells. Okay, so you have mixed inflammatory cells in the background, and in between you will see the tumor cells or the Reed-Sternberg cells. Okay, so this tumor, the Hodgkin's lymphoma, it was first described by Thomas Hodgkin in 1832. Okay, and the cell, that is the neoplastic cell, which is the Reed-Sternberg cell now, it was first described by Dorothy Reed and Carl Sternberg. Okay, that is why the cell has been named after them. That is Reed and Sternberg. Okay, Reed-Sternberg cell. Going on to classification, historically, a lot of classifications have been given for Hodgkin's lymphoma. Okay, but the WHO 2017 classification broadly classifies Hodgkin's lymphoma into two categories. Okay, one is classical Hodgkin's lymphoma, and another is lymphocyte predominant nodular type. Okay, what is the difference between classical Hodgkin's lymphoma and lymphocyte predominant nodular type? We will see. Okay, so in classical Hodgkin's lymphoma, the cell, the tumor cell or the neoplastic cell that you see is the classical Reed-Sternberg cell. What do you mean by classical Reed-Sternberg cell? The Reed-Sternberg cell, the lineage of this Reed-Sternberg cell, from where does it come? Okay, so there are two schools of thought. The most accepted school of thought is that Reed-Sternberg cell has a B cell lineage. Okay, it has a B cell lineage. The B cells which are not able to form any immunoglobulins. Okay, those B cells are these Reed-Sternberg, are transformed into Reed-Sternberg cells. That is one school of thought which is most popular, and all the classical Hodgkin's lymphoma is based on this school of thought. Okay, the another school of thought is that this Reed-Sternberg cell, it has a histiocytic lineage. Okay, it has a histiocytic or a macrophage lineage. Okay, and the tumor, that is lymphocyte predominant nodular type of Hodgkin's lymphoma, the cell which is seen in that is called as popcorn cell or L and H cell. L and H means lymphocyte and histiocyte cell. That is seen in lymphocyte predominant type of Hodgkin's lymphoma. That is why Hodgkin's lymphoma is classified into two types. Classical Hodgkin's lymphoma, which believes that the tumor cell is the Reed-Sternberg cell, which is coming from a B cell lineage, and lymphocyte predominant type or nodular type, which believes that the tumor cell, that is the popcorn cell or L and H cell, is coming from a histiocytic or macrophagic lineage. Okay, so these are two major types of Hodgkin's lymphoma: classical Hodgkin's lymphoma and lymphocyte predominant Hodgkin's lymphoma. Okay, classical Hodgkin's lymphoma, further it is classified into four types. Okay, nodular sclerosis, lymphocyte rich, mixed cellularity type, and lymphocyte depleted. Nodular sclerosis means you will have the tumor cells or the tumor the architecture will be, it will be seen in nodules. Okay, and in between you will see lot of fibrosis. Okay, you will see lot of fibrosis. That is nodular sclerosis. Nodular sclerosis is defined by three things. Okay, you will have lacunar type of Reed-Sternberg cell. What is this? That we will see later. It will have sclerosis, that is fibrosis, and you will have areas of necrosis. Okay, and nodular sclerosis has the best prognosis among all the types of Hodgkin's lymphoma. Okay, then the next type is lymphocyte rich type, where, as the name suggests, the most common background non-neoplastic cell will be lymphocytes. Okay, the most common non-neoplastic background cells will be lymphocytes. Again, that is lymphocyte rich. Again, very good prognosis. Okay. Next is mixed cellularity type, where again you will have Reed-Sternberg cells, which are the neoplastic cells. You will have a background of non-neoplastic cells. That background of non-neoplastic cells will be mixed cellularity type. Okay, so you will have lymphocytes, you will have plasma cells, you will have neutrophils, and more commonly you will see eosinophils. Okay, so mixed cellularity type, the background cells will be all the types: lymphocytes, neutrophils, plasma cells, and eosinophils. That will be mixed cellularity type, and again it will show show a good prognosis. Okay, and finally you have the lymphocyte depleted type, where here the background cells, the lymphocytes will be very less. Okay, which the immune cells will be less. So what will happen? The prognosis will be poor. Okay, so among all the types of Hodgkin's lymphoma, the most poor prognosis will be shown by lymphocyte depleted type of Hodgkin's lymphoma. But luckily, this type is very uncommon. Among all the Hodgkin's lymphoma, only 5% is lymphocyte depleted type of Hodgkin's lymphoma. Okay, so this is the classification of Hodgkin's lymphoma. Okay, so going on to the epidemiology. So the incidence, it is very rare tumor. Okay, among all the Hodgkin's lymphoma, among all the lymphomas, Hodgkin's lymphoma is only 20%. Okay, so it's very rare. Among 1 lakh population, only 2.5 people are affected. Okay. Then the male predilection is seen in Hodgkin's lymphoma, except one type, that is nodular sclerosis type. Okay. In nodular sclerosis type, you will have a female predilection. How will you remember this? Nodular sclerosis. Okay. Roses means, remember rose. Okay. So rose is a female name, right? So you will have a female predilection in case of a nodular sclerosis type of Hodgkin's lymphoma. All other subtypes, they will show a male predilection. Okay, and you will see age groups in which Hodgkin's lymphoma is seen. Hodgkin's lymphoma is seen in a bimodal age group. Okay, first it will be seen in, it can be seen in children or in the late adults. Okay, or in the adulthood. Okay, in the childhood it will be between 0 to 4 years, 14 years. Young adults will be 14 to 40 years, and old adults will be 55 to 74 years. Okay, so this will show a bimodal age presentation. So there is no particular single risk factor or etiological factor that has been attributed to Hodgkin's lymphoma, but there are several implicated factors. Okay, the most common implicated factor is the EBV or Epstein-Barr virus infection. Okay, almost 5 times the risk is increased when there is an EBV infection in association with infectious mononucleosis. Okay, again, HIV infection is also has a higher risk of transmission of or higher risk of development of Hodgkin's lymphoma. Okay, certain occupational hazards like woodworking or farming will have a risk of association of Hodgkin's lymphoma. Okay, if you have a first degree relative, okay, either your mother or father or brother or sister or either of the siblings, they have Hodgkin's lymphoma, then you have a 5-fold increased risk of development of Hodgkin's lymphoma. So first degree relatives have a 5-fold increased risk of development of Hodgkin's lymphoma. Okay, if you have a history of prolonged use of hormone growth factor, or if they belong to a higher socioeconomic status, or you are associated with EBV infection, again you are at an increased risk of development of Hodgkin's lymphoma. Okay, and as I already told you, males are more prone to development of Hodgkin's lymphoma, and racially speaking, white population is at a more increased risk of development of Hodgkin's lymphoma as compared to blacks and Asians. Okay. Moving on to the clinical features, as a typical lymphoid malignancy, you will definitely see a lymphadenopathy. Okay, most commonly in the cervical lymph nodes. But this lymphadenopathy is painless. Okay, so always remember, any lymphadenopathy which is associated with an infection tends to be painful, whereas a lymphadenopathy associated with a malignancy tends to be painless. Okay, so you will have a painless lymphadenopathy most commonly in the cervical lymph nodes. Okay. Then you will see some B symptoms. What are B symptoms? Fever, swelling of the face and the neck, okay, lymphadenopathy, excessive sweating, okay, breathlessness, unexpected weight loss, pruritus or itching sensation, weakness. All these are B symptoms. Okay, so these B symptoms will be seen in case of um, Hodgkin's lymphoma. Okay. Then another very specific sign which is associated with the Hodgkin's lymphoma is pain in the involved nodes after alcohol consumption. So this is very specific to Hodgkin's lymphoma. If you consume alcohol, whatever involved nodes are there, they will become painful. Okay, that is a specific sign of Hodgkin's lymphoma. Okay, these are the clinical features. Going on to pathogenesis. So as I told you, the lineage that is expected or that is seen is B cell lineage. Okay, so where will be the B cells? They will be the germinal centers. Okay, this is a germinal center. Okay, so you can see this is a naive B cell, and because of something, because there is a proliferation, okay, or because of some mutation, because of EBV or any other factor, they can have two kinds of mutations. You can have favorable mutations and crippling mutations. Okay, if there is a favorable mutation, there are two possibilities. Okay, either they will form high affinity memory B cells, or that is the first possibility. Second possibility is there will be some transforming events. What are transforming events? In this case, the transforming event is that there will be a transformation of this cell, this B cell, into L and H cell. Okay, there will be a transformation to L and H cell. Why is this transformation taking place? We will see in the next slide. Okay, so there's a transformation which is taking place, and this naive B cell is getting transformed to a L and H cell, which is responsible for lymphocyte predominant type of Hodgkin's lymphoma. Okay, this is, there is a favorable mutation. If there is a crippling mutation, what will happen? There are two possibilities. Again, either the cell can undergo apoptosis and die, or if the cell survives, okay, then it can again transform and it can undergo transformation to form a Reed-Sternberg cell. This Reed-Sternberg cell will be the classical Reed-Sternberg cell with the B cell lineage. Okay, so this is what is happening inside the germinal center. Okay, So there is any risk factor, for example, EBV infection, right? So EBV infection, because of which what will happen, the B cells will get infected, and what is changed, what is the transformation that is taking place? There is a VDJ recombination somatic hypermutation. Okay, so the VDJ recombination is taking place in the B cell, and it is undergoing a change. Okay, it is undergoing a mutation. Okay, these cells will express LMP1, which is the protein encoded for EBV genome, and because of this LMP1, what will happen? There is an upregulation of NF kappa beta. So it is NF kappa beta. It is a proliferation marker. Okay, it is a proliferation. What do you say? Transcription factor, and this is like a switch. Okay, NF kappa beta. If it upregulates, that switches get on, and there will be excessive proliferation. Along with excessive proliferation, what is happening? The apoptosis is going down. Okay, there is a apoptosis which is going down, because of which there is excessive proliferation and survival of these mutated cells, and which will lead to formation of Reed-Sternberg cells, and ultimately it will lead to development of Hodgkin's lymphoma. Is that clear? So there is an oncogenic transformation to the Reed-Sternberg cell from the B cell. Okay. So one very peculiar feature about Reed-Sternberg cells or about Hodgkin's lymphoma is that among the total tumor volume, the tumor cell, that is the neoplastic cell, which is the Reed-Sternberg cell, it comprises only 1 to 3%. Okay, 1 to 3% is all that the tumor cells are present in the entire tumor volume, right? But still it produces all the signs and symptoms. How is that possible? What happens is, these classical Reed-Sternberg cells, they produce lot of cytokines, okay, lot of interleukins, lot of other inflammatory cytokines, okay, and these inflammatory cytokines, they recruit the inflammatory cells into the tumor site. Okay, so for example, this Reed-Sternberg cell, it releases a cytokine called as eutaxin. Eutaxin is responsible for recruitment of eosinophils. Okay, so when this Reed-Sternberg cell secretes eutaxin, what will happen? This eutaxin will attract the eosinophil to that side, and eosinophil will come to the tumor site. Okay, similarly, this Reed-Sternberg cell, it will release interleukin 8. Okay, interleukin 8. This interleukin 8 is responsible for recruitment of neutrophils. Okay, it is responsible for recruitment of neutrophils. So neutrophil will come to the tumor site. Similarly, Reed-Sternberg cell will secrete interleukin 4. Interleukin 4 is responsible for recruitment of B cells or the lymphocytes. Okay, it will release some other inflammatory cytokine like CXCL16, which is responsible for recruitment of plasma cells. So plasma cells will come to the picture. Similarly, it will secrete all these inflammatory mediators. Apart from that, there are other also like bone morphogenic proteins and tumor necrosis factor. All these will be secreted by this Reed-Sternberg cell, which will lead to the signs and symptoms. Okay, that is a very peculiar feature of Hodgkin's lymphoma. The tumor cells are very less, but they recruit the other neighboring cells, and they will lead to formation of the tumor. Okay, or the symptoms of the tumor, right? So this is a gist of the pathogenesis, right? So we have a germinal center B cell. Okay, because of the transforming events, for example, EBV, it is getting transformed into a Reed-Sternberg cell. Okay, so in Reed-Sternberg cell, what is happening? There is loss of apoptosis and proliferation, and these Reed-Sternberg cells, they will release the cytokines which will attract the inflammatory response. Okay, so the tumor cell will be composed of the Reed-Sternberg cell, which is the neoplastic cell, and the background non-neoplastic mixed inflammatory cells. Is that clear? Going on to the gross picture. Okay, so grossly, when you cut a lymph node which is infected or which is affected with Hodgkin's lymphoma and you palpate it, you will feel a fish flesh consistency, okay, or a rubbery consistency. And when you see the gross picture, you will see that these tumors areas are, it has a nodular appearance. Okay, it has a nodular appearance, and when you palpate it, you will feel a fish flesh or a rubbery consistency. Okay. Going on to the histopathological features. So histopathologically, you have to see two things. You have to see the neoplastic cells. Neoplastic cells will be the Reed-Sternberg cells, and you will see the background non-neoplastic inflammatory cells. Okay. So the neoplastic cells are the Reed-Sternberg cells. Okay. This is a classical Reed-Sternberg cell. Reed-Sternberg cell, it is a B cell lineage, and this is a large cell. Okay, a large cell, multinucleated. Okay, classical Reed-Sternberg cell will be binucleated. Okay, and it will have large nucleus. Okay, and it will have a prominent nucleoli. Okay, so it has a large cell with cytoplasm, foamy cytoplasm, large binucleated cell. Okay, there will be two nuclei and two prominent nucleoli. The nucleoli will be eosinophilic. Okay, the nucleoli will be eosinophilic, and you will see a halo surrounding the nucleoli. Okay, here you can see a large red Sternberg cell which is undergoing mitosis. Okay, this is a larger picture. Okay, you can see a large cell with a vesicular or a foamy cytoplasm. Okay, then you have two nuclei, large nuclei. Okay, inside the nuclei, what you are able to see is a eosinophilic nucleoli, prominent nucleoli. It gives a typical owl-eye appearance. Okay, owl-eye appearance. This is a typical owl-eye appearance. Okay, here also you can see large cell with nucleol, two binucleated cell. Okay, and here you can see prominent nucleoli which are eosinophilic or pink in color. Okay. So there are some variants of these Reed Sternberg cells also. Okay, this is multinucleated variant where you can see more than two nuclei. Okay, you can see 1, 2, 3, 4, 5, 6 nuclei, and each nuclei has a prominent nucleoli. Okay, this is also a multinucleated variant of Reed Sternberg cell, and this is a typical floret pattern or a flower-like pattern of Reed Sternberg cell. Again, a variant of multinucleated Reed Sternberg cell. Okay, then sometimes you can see a single nucleus. So that is mononucleated Reed Sternberg cell. You can see a large cell with a single nucleus and a prominent nucleoli. And here you can see a lot of inflammatory cells. What you can see, a lot of eosinophils are also visible. And here also you can see mononucleated Reed Sternberg cells. Okay. Then in a certain type of Hodgkin's lymphoma, which is the nodular sclerosis type of Hodgkin's lymphoma, you will be able to see these kind of cells. These are called as lacunar cells. How is it different from the previous cells? You can see in the lacunar cells that the cell is in a lacuna or in a bay kind of a thing. Okay, so this is a lacuna, and the cytoplasm has now folded. Okay, why? This is because of the formalin fixation. Okay, so because of the formalin fixation, the cell has shrunk, or the cytoplasm has shrunken or folded, and you can see a lacuna around the cell. So this is very, very commonly seen in nodular sclerosis type of Hodgkin's lymphoma. Okay. And finally, you will have some Reed Sternberg cells which have undergone apoptosis. Okay, so that is called as a mummified Reed Sternberg cell. You can see here a large cell, but the nuclear details have been lost. Okay, this is a normal Reed Sternberg cell, mononucleated, and this is a classical Reed Sternberg cell. And here you can see the mummified Reed Sternberg cell. Okay, it is dead. Okay, apoptosis has taken place. So these are the different types of Reed Sternberg cells. Okay. So again, in electron microscope, you can see this large cell with the two nuclei and a prominent nucleoli. Okay, so that is a classic Reed Sternberg cell. Then we go on to the background cells. As I told you, the background cells will be the non-neoplastic cells. Those will be plasma cells. You will have eosinophils, you will have lymphocytes, neutrophils. Okay, all these are the background cells which will be present. Okay. And going on to the histopathological classification of Hodgkin's lymphoma, as I told you, you will have two major types: the classical type and the lymphocyte predominant nodular type. Okay, in the classical Hodgkin's lymphoma, you will have four types: nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depletion. Okay, so nodular sclerosis, as I told you, it has three features: fibrosis, lacunar cells, and necrosis. Okay, so you can see here there is an area of fibrosis. Okay, here the fibrosis will be parallel. Okay, they will be parallel. This fibers will be arranged, the collagen fibers will be arranged parallelly, and they will show birefringence. Okay, they will show birefringence, and you will see typical lacunar cells. Okay, you can see all these are the lacunar cells, lacunar Reed Sternberg cells. Okay, and you will see lot of fibrosis. You can see the cells are arranged in nodules, and you can see fibers which are parallel to each other, which are arranged across the nodules. Okay, here also you can see an area of necrosis. Here, can you see? This is the area of necrosis. This is the area of the lymphocytes, and this is the area of the tumor cells. You can see a lot of lacunar cells. Okay, here you can see a lacunar cell. Here you can see a lacunar cell. Okay, so this is a typical nodular sclerosis. Okay. There are two phases in nodular sclerosis. One is a cellular phase, where you will have a central Reed Sternberg cell or the neoplastic cell, which is surrounded by the non-neoplastic inflammatory cells. Whereas, okay, here also in the larger picture, you can see you have a lacunar cell which is surrounded by the lymphocytes. Okay. Whereas in the syncytial variant, what is syncytial variant? Syncytial means band or a sheet of cells arranged. Okay, sheets of cells. So here you can see the lymphocyte, the tumor cells, the Reed Sternberg cells, they're arranged in the form of sheets with very few inflammatory cells in between. Right here also you can see excessive fibrosis is seen, and there are nodules of cells which are present. Okay, nodules of tumor cells and along with the inflammatory cells which are present. That is the syncytial variant of nodular sclerosis. Okay. Where you can see some nodules of the tumor cells and in between extensive fibrosis, and in the central area you are able to see area of necrosis. Okay. So going on to immunophenotype, that is the immunohistochemical features of the classical Reed syndrome or nodular sclerosis. Remember, in classical Hodgkin's lymphoma, all the four subtypes, you will have the Reed Sternberg cells. These are classical Reed Sternberg cells. Okay, so they will all show positivity for CD15 and CD30. Okay, all Reed Sternberg cells will be positive for CD15 and CD30. Only in the last variant, that is lymphocyte predominant variant, where the lineage is histocytic lineage, there you will have CD15 and CD30 negativity, and CD45 and CD20 will be positive. Okay, so in all the other four classical types of Hodgkin's lymphoma, you will have CD15 and CD positivity localized to the Reed Sternberg cells. Okay, so you can see the Reed Sternberg cells have nicely taken up CD15 or 30. Okay, here you can see CD30 positivity. All the tumor cells, all the neoplastic cells have taken up CD30. Whatever has not taken up, that is the normal lymphocytes. Okay. And as I already told you, because of nodular sclerosis showing fibrosis and all those things, and lot of lymphocytes, nodular sclerosis has the best prognosis among all the other types of Hodgkin's lymphoma. Okay. Moving on to mixed cellularity, as the name suggests, here also you will have Reed Sternberg cells as the neoplastic cell, but the non-neoplastic inflammatory background will have mixed cellularity. It will have plasma cells, lymphocytes, neutrophils, and very commonly eosinophils. You can see a lot of eosinophils in mixed cellularity type of Hodgkin's lymphoma, and it will show a good prognosis. Okay, not the best prognosis, but a good prognosis will be seen in mixed cellularity. You can see this Reed Sternberg cell, and there are a lot of inflammatory cells. You can see some neutrophils, you can see some eosinophils. Okay, plasma cells are also seen. Okay, so here is a plasma cell. This is a classic Reed Sternberg cell. Here is a eosinophil. Okay, so these are all seen in mixed cellularity type of Hodgkin's lymphoma. Okay, and again, immunophenotype, definitely you will see CD50 and CD30 positivity. FASN positivity again will be seen, and EBV positivity will be seen in 75% of the cases. Okay, that is seen in mixed cellularity type. Next, we go on to lymphocyte depletion. As the name suggests, now in the background, lymphocytes are present, and that lymphocytes are depleted or they are less. So what will happen? Immunity is down. So what will happen? The prognosis will be very poor. So among all the subtypes, lymphocyte depletion shows the worst prognosis. Okay, but luckily it is not very common. Only 5% is lymphocyte depletion. Okay, so in lymphocyte depletion, what will happen? You will again see the Reed Sternberg cell, but in the background, lymphocytes will be less. So you can clearly see here many Reed Sternberg cells are there, but lymphocytes are very less. Okay. So in this also you have two types. One is a diffuse fibrosis variant where you will see some fibrosis in between. Okay, but that fibrosis will be diffuse. Okay, they will not be well arranged. They will not be parallel to each other. Okay, whereas in reticular variant there will be a lot of empty spaces in between. Okay, and here what you will see, you will see a classic Reed Sternberg cell, but the background lymphocytes will be very less. Okay, so immunophenotype, again, the tumor cells will show CD15 and CD30 positivity, FASN positivity, and EBV positivity will be seen in 100% cases with HIV infection. Okay, so that is an important point to remember in lymphocyte depletion. Poor prognosis, lymphocytes will be less. Then lymphocyte rich, as the name suggests, again prognosis will be good. You will have the Reed Sternberg cells, and the background inflammatory cells will be rich in lymphocytes. Okay, with a good prognosis. Clearly, you can see lot of lymphocytes are present. Okay, and you can see the tumor cells in between. Okay, these are the Reed Sternberg cells, and those Reed Sternberg cells will be positive for CD15 and CD30, and FASN positivity will also be seen. In the background, lymphocytes are also clearly visible. Okay. Finally, we come to lymphocyte nodular lymphocyte predominant type, where here what is happening? Here the tumor cell is not a B cell lineage cell; it is a histiocytic lineage cell. Okay, so this is called an L and H cell or a popcorn cell. Okay, here also your predominant inflammatory cells will be lymphocytes only, but the cell, the tumor cell, will be called as a popcorn cell. Okay, it will have the nucleus will be slightly this cytoplasm will be slightly shrinked or wrinkled. It will look like a popcorn. Okay, so that is what is called a popcorn cell or a L and H cell. Okay. Here also you can see nice L and H cells. Okay, these are the L and H cells. Okay, and in the background you are seeing a lot of lymphocytes. Okay. So here also very clearly you can see these L and H cells, and the background cells are filled with lymphocytes. Okay, that is lymphocyte predominant nodular type of Hodgkin's lymphoma. Okay, and when you go for the immunohistochemistry, here the tumor cells will be CD15 negative, CD30 negative. Okay, so what all the Reed Sternberg markers were there? They were negative, and CD45 and CD20 is positive. Okay, CD45 and 20 will be positive. So when you get a Hodgkin's lymphoma, what you have to do is you have to run a panel of IHC markers. Okay, your pan B and pan T cell markers will run. Apart from that, to localize or to identify the type of Reed Sternberg cell, you have to put 2 to 4 markers. Okay, CD15, CD30, CD45, and CD20. You have to put this and see the tumor cells are taking up which marker. If it is taking CD45 and CD20 positivity, it indicates that the tumor is a lymphocyte predominant type of Hodgkin's. If it is CD15 and CD30 positivity, it means it is a classical Hodgkin's lymphoma. Then based on the amount of inflammatory cells and based on the background inflammation, we have to further type the tumor as which type. Okay, is it nodular sclerosis? If there is necrosis, fibrosis, Lacuna cells, it will be nodular sclerosis. If there are a lot of eosinophils, plasma cells, neutrophils, it will be mixed cellularity. If the lymphocytes are very less, then it will be lymphocyte depletion. If the lymphocytes are excessive or more, it will be lymphocyte predominant. Okay, sorry, not lymphocyte predominant, lymphocyte rich. Okay, and if CD30 and 15 are negative, 45 and 20 are positive, and a lot of lymphocytes are seen, then definitely it is nodular lymphocytic predominant type of Hodgkin's lymphoma. Okay. Then this immunophenotype we have already seen. Okay, so going on to investigations. So when we go for a CBC, complete blood picture, what you will see normocytic normochromic anemia. Okay, and you will see increased in the WBC. Okay, increase in the WBC. Then your elevated ISR will be seen. ESR, erythrocyte sedimentation rate will be elevated. Okay, and HIV we have to do to rule out the HIV infection. Okay, HIV test should be done. Then usually we go for a core needle biopsy, but if you are confused if it is a lymphoid malignancy or a tumor metastasis, we go for an FNAC. In FNAC, what you're expected to see in Hodgkin's lymphoma, you will see definitely the Reed Sternberg cells, okay, classical Reed Sternberg cells, and you will see a lot of mixed inflammatory background. Okay, this you can see in FNAC. Okay. Then going on to some differential diagnosis, how will you differentiate between a classical Hodgkin's lymphoma and a lymphocyte predominant Hodgkin's lymphoma? Obviously with CD markers. Okay, CD15 and 30 will be negative for lymphocytic predominant. Okay, what will be positive? CD45 and 20 will be positive for lymphocyte predominant Hodgkin's lymphoma. Okay. Then in Hodgkin's lymphoma and small lymphocytic lymphoma, what will be the difference? Here, the tumor cells will be more in number. Okay, and the tumor cells will be the lymphocytes. Okay, so the larger cells which look like Reed Sternberg cells are not actually Reed Sternberg cells. They will be pro-lymphocytes and para-immunoblasts. Okay, and you can do a CD5 test, and that CD5, the tumor cells will be positive for CD5, which will not be the case for Hodgkin's lymphoma. In Hodgkin's lymphoma, if it is classical, it will be CD15 and 30 positivity. Whereas if it is a lymphocyte predominant, your CD45 and 20 will be positive. Okay. Then differentiating Hodgkin's lymphoma from a diffuse large B cell lymphoma. Again, here the large cells will be the tumor B cells and not the Reed Sternberg cells. Okay, so CD20 and 45 will be positive here, but apart from that, you will have 22 and 19 positivity also. All the B cell markers will be positive. Okay, whereas CD15, CD30 all will be negative. Okay, in case of diffuse large B cell lymphoma. Okay. Then in anaplastic large cell lymphoma also, CD45 and EMA all will be positive, but CD15 and 30 will be negative, and the anaplastic cells will show multiple red-like nuclei. Okay. You can clearly make out the difference because the tumor cells in Hodgkin's lymphoma will be very less. Okay, and those tumor cells will be typical Reed Sternberg cells, whereas anaplastic large cell lymphoma, the major component will be tumor cells. Okay, in Hodgkin's lymphoma, the major component are actually the non-neoplastic inflammatory cells. Okay. Now, clinical staging is very important for Hodgkin's lymphoma because we have to determine what treatment we should give to the patient. Okay, should we only go for chemotherapy or should we go for chemotherapy with radiotherapy? Okay, for that, doing a CT scan or a PET scan and determining the critical staging is very, very important. Okay, that clinical staging is given by Ann Arbor staging, okay, or Ann Arbor classification, and it is based on the level of lymph nodes or the amount of lymph nodes which are involved. Okay, so there are 4 stages: stage 1, 2, 3, 4. Stage 1 is where you will have a single node which will be involved. Okay? Either a single node will be involved or single extra lymphatic or extranodal region will be involved in stage 1. In stage 2, you will have 2 or more lymph nodes or 2 or more extranodal involvements which will be seen, but they all will be seen on one side of the diaphragm. So diaphragm is something which separates the thoracic cavity with the abdominal cavity. Okay, so whatever involvement you are seeing, you will see on the same side of the diaphragm. That is in stage 2. In stage 3, what you will see that there are multiple nodes and extranodal involvement is seen on both the sides of the diaphragm. Okay, so it will cross the diaphragm and it will go on either sides. Okay, that is stage 3. And in stage 4, you will have a disseminated disease where you will have nodal involvement, extranodal involvement, your liver, spleen, and all will be involved. Okay, so all this will be seen in stage 4. Okay, this is the Ann Arbor staging for Hodgkin's disease or Hodgkin's lymphoma. Okay. Now, going as far the prognosis is concerned, there are some prognostic factors, okay, which are taken into consideration to predict the prognosis. As I told you, Hodgkin's lymphoma usually has a favorable prognosis unless it is a lymphocyte depletion. Okay, so the amount of tumor cells. Okay, what is the amount of tumor cells present? What is the measurement of the tumors? Okay, all this will lead to a prognosis. Okay, all this will indicate a prognosis. If the tumor cell percentage is more, prognosis will be less. Okay, and vice versa. Then the spread of the tumor cells. Okay, if the tumor is disseminated, she's showing a disseminated spread, obviously the prognosis will be poor. Whereas if it is a contained or a limited spread, the prognosis will be better. Okay. Then growth characteristics. If there is cellular proliferation, if it is more and apoptosis is less, means the prognosis will be poor. Okay. Again, there are some tumor whose interactions, interactive these things, factors like LDH level. If the LDH level is more, then the prognosis will be poor. And if these symptoms are seen, again the prognosis will be poor. Okay, so all these are some of the prognostic factors. And there are some prognostic markers, like I told you, LDH level will be more. Okay, so LDH level indicates that it reflects the total amount of tumor cells. Okay, so if LDH levels are more, means the tumor cells are more, so the prognosis will be poor. Okay, if CD30 soluble amount of CD30 in the blood, if that is more, means again the Sternberg cells are more, so your prognosis will be poor. Okay, then certain proliferative markers like 567, PCNA, P53, retinoblastoma. If these markers are if the amount of these markers are more, these proliferative markers are more, so the prognosis will be poor. Okay, BCL2 is an anti-apoptotic marker. So if BCL2 marker is elevated, means the prognosis will be poor. The PCL2 and caspase-3 will be reciprocal. So if BCL2 is elevated, prognosis will be poor. If caspase-3 is elevated, prognosis is better. Okay? If caspase-3 is elevated, prognosis will be better. And finally, if there are low levels of serum albumin, it indicates worse prognosis. So these are some prognostic markers which can help in identifying or in predicting the course of the tumor, or how the patient will respond to the treatment. Okay, so with this we finish the topic. Okay, so thank you so much for your time. Okay, and I hope I could enlighten, I could share some points with you. Okay, so yes, thank you so much.